This mini lecture is going to be on osteoporosis, which is a disease where there's increased bone weakness, increasing the risk of a broken bone. So it's the most common reason for broken bones among the elderly population. In patients who are osteoporotic, there is normal bone mineralization, but the bone mass is low. So that's why we call it bone mineral density. There's also some manifestations of vertebral and hip fractures, although these are usually can occur at any skeletal site. We see them more in the spine and the bones of the forearm and also in the hip. And until there's a broken bone, there really are no symptoms that the patient does have. When we look at the contrasting this with osteopenia, that is a less severe form of decreased bone mineral density, and the numbers are a little bit different in this patient population. So you'll see when you're doing the scores on these patients, those are lower. So this is a preventable disease, and one of the reasons that we try to do screening for patients is because there are ways that we actually can prevent this from occurring. It does affect both genders, but females significantly more than males. And when you look at the numbers, it is really roughly 4 out of 10 women who are in the Caucasian age group older than 50 that will get a hip or a spine or a wrist fracture. And about 10 million individuals older than 50 in the United States have osteoporosis of the hip. But you see it much more in this patient population of the females. Postmenopausal women have a significant history of getting osteoporosis. Bone loss after menopause is usually predominantly by estrogen deficiency, and it is the most rapid in the first decade after menopause. So postmenopausal osteoporosis is very prevalent in white and Asian women, and much more than in women of other races. And the majority of white women develop it by the end of their first postmenopausal decade. So by age 65, at least 1/3 of women will have some type of fracture, and by the 9th decade, 1 in 3 will have some evidence of hip fracture. Men are often undiagnosed with osteoporosis. We don't think to do bone mineral density tests on these patients, although they definitely should have this done. It's we have a tendency to forget about the men when this comes to getting osteoporosis. Testosterone deficiency because of hypogonadism is one of the common causes of osteoporosis in men. And so we really need to be looking at that when we're thinking and measuring their bone mineral densities. After 75 years old, these fractures occur at the same rate in men and women, and we call it the early silent disease because there usually is not any real type of symptoms that the patients have. They're very asymptomatic until they break a bone. They may have some late back pain, some height loss, some kyphosis, scoliosis, and sometimes when you see that dowager's hump on the back of women, and they're kind of crumped down, that they probably are osteoporotic. There are primary and secondary causes, but the cause of osteoporosis is really multifactorial. There's genetic factors, which are important determinants of bone density, lifestyle, disease-related issues, medication-related factors. When we're thinking about the disease-related, someone who has thyrotoxicosis, Cushing's syndrome, rheumatoid arthritis, any type of the autoimmune issues can cause problems, as well as advanced age, somebody who is postmenopausal, and somebody who has a genetic component. Females, we do know, as well as Asian or Caucasian, are at an increased risk, as well as somebody who has low weight or a low BMI. The primary diet risk factor for osteoporosis is the lack of adequate calcium in the diet throughout the life cycle. And the majority of cross-sectional studies have looked at supporting that long-term inadequate dietary calcium has significant effects on bone mass. So it's really important that we're making sure that these patients have adequate calcium and phosphorus and vitamin D intake, especially as children. Hormonal deficiencies we talked a little bit about because of the lack of estrogen, and women who have bone loss this increases after menopause due to those low levels of estrogen. Long-term medication use, when we're thinking about using glucocorticosteroids or even the thyroxines and the dilantin. And then also inactivity. Women who are not active have a tendency to get more, uh, have a tendency to either be osteopenic or osteoporotic. There is increasing evidence that muscle strength training can actually prevent further loss of bone mineral density in women who are postmenopausal. Some of the risk reduction measures that we need to look at are, taking insufficient lifetime calcium, as I said, starting that as at an earlier age, as with young adults, because they really should not be underestimated that the vitamin D intake is sufficient for some of these patients, as well as the calcium intake. Daily exercise and preventing falls is another risk reduction measure, as well as avoiding cigarette smoking. It's really been established that loss of bone density with cigarette smoking has really been correlated also with a reduction in circulating estrogen levels. So, and there's also been some studies done on the toxic effects of cigarette smoking on the osteoblasts. So it's important that we do discuss that with the patients. And also avoiding excessive alcohol intake and getting regular dental care. Some of the common differentials when we're looking at patients with osteoporosis, if a fracture's occurred, it's really important to distinguish the underlying cause of it. So, was it related to trauma, or was there an underlying pathological condition such as osteoporosis or even a cancer? There's skeletal changes that could result from a variety of underlying conditions, such as maybe a multiple myeloma or even a cancer or hyperparathyroidism, some type of hyperthyroidism, or even osteomalacia. So we have to rule out these diseases that could lead to secondary causes of osteoporosis. There's many that are listed here, GI issues, the autoimmune disorders, the central nervous system disorders. There's many different things that can be causing osteoporosis that we need to rule out before we start treating. So as we want to start our focused assessment on these patients, we use our old carts and think about when this did occur. When is the onset? What is the duration? Do you have pain? Have you had previous histories of fractures, loss of height? What has your dental health been? So getting a really thorough a history and physical exam on the patient is very important. When we're looking at doing our objective, which is your physical examination, we always want to measure the height every year and determine if there's been any loss. Looking at the kyphosis and the lordosis of the back, palpating the spine. Do they need a full physical, exam to detect, secondary causes? As the bone density decreases, there could be some microfractures of the anterior vertebral bodies in the thoracic spine, and that's when you see that dowager's hump, where we call that the dorsal kyphosis. Also looking at and cueing into helping to identify those risk factors. As this kyphosis worsens over time, then you may see impairment of the rib mobility too, because of the way that they're leaning. You can also maybe see some lung changes in lung volume, as well as respiratory issues that can develop with this if their spine is really affected. So what are we doing for diagnostic testing on these patients? Well, we do bone mineral density testing, and many of the insurance companies now are not allowing this to be done except for maybe every 3 years. It's really important to identify those patients that can be at risk and start testing them early on, using those risk assessment tools that are available, and using there's one called the SCORE, which is the Simple Calculated Osteoporosis Risk Assessment Tool, and it helps to estimate, the sensitivity and the specificity for someone who does have low mineral density at the hip. There's also the DEXA scan, which is your most accurate. A lot of these technologies have really improved over the years, and the methods are considered accurate, but the DEXA method is the most widely accepted because of the epidemiological studies that have found it to be the most precise. And it's been the most precise for reproducing in both the short as well as the long term. So it makes it an excellent method for monitoring the interventions over time. So you can look at the changes that have occurred over time. It is really the best hip predictor. When we're looking at measuring bone density, the reports are interpreted by using z-scores as well as t-scores, and the both use a normally distributed bell curve to determine how any one individual will compare, and they're comparing it to a reference population. So the z-scores are representing age and sex-matched distribution, but the t-scores are representing the mean peak bone mass of young adult distributions. So we really, when we're looking at in the clinical arena, we look at the t-score because it's the most relevant value on the BMD to confirm osteoporosis. And for every standard deviation below that young adult matched mean, there's a significant increase in risk fracture. With the osteoporosis, they do need a BMD every 1 to 2 years, and as long as you do have a diagnosis of osteoporosis, you can get that covered. But if you're just doing a screening, usually you can't get the screening done for every 3 years. Medicare has approved the indications for bone mineral density testing, including estrogen deficient women who are at high risk for osteoporosis, if the patient has vertebral abnormalities, if they're receiving glucocorticoids long term, if they do have primary parathyroidism, and if they're being monitored for osteoporosis with drug therapy, then Medicare will go ahead and approve those. Some of the secondary causes of osteoporosis really do need to be considered in all patients that have low bone density. So we're looking at, other diagnostic tests. So we have to do some blood work to establish baseline conditions and in the secondary causes. So looking at a CBC as well as a serum chemistry panel, making sure that the calcium, the phosphate, the liver enzymes, your alk phosphate, creatinine, the electrolytes, and a pH are included in these. And there's AACE guidelines, and those guidelines could be warranted if there are abnormalities in thyroid levels also, as well as 24-hour urine calcium excretion and SED rates. You can also get the 25-hydroxy vitamin D concentration covered too. So this is another test that needs to be done on these patients. When we're thinking about management, the goals for either the prevention or the treatment of osteoporosis are to prevent fractures, stabilize the patient, improve bone mass, maximize their physical functioning, and to relieve their symptoms of fractures. So the ability to meet these goals is really dependent on both the patient and also your dedication to work with the patient to determine what is the best therapeutic regimen for them to be getting. So adequate calcium and vitamin D intake, looking at the pharmacological treatment, so looking at doing calcium intake and vitamin D supplements. So when we're thinking of the adults age 19 to 50, they should be taking no less than 1,000 milligrams of calcium daily. And older adults should be on 1,200 milligram. And if they're over 50 and they have low bone mass, then they should be right around 1,500 milligrams a day. I usually try to keep everyone right around 1,200 unless they have, really low bone mass on the DEXA scan. You can also give them about the same amount of vitamin D that is necessary too. And many of these patients take vitamin D over the counter. But if they're taking vitamin D over the counter, they need to be taking at least 800 to 1,000 units a day if they're over 50 years old. And I think a lot of times we're putting patients now on even more vitamin D because of the risk of low vitamin D levels of heart disease, as well as colon cancer. So there's a lot of links there with low vitamin D levels in that. So we're really putting patients on higher doses even, which helps them with osteoporosis. Doing the biphosphonates with special dosing, we need to be looking at those medications. Fosamax is one of them, Fosamax, or even the uh, Actonel. Sorry, I couldn't think of the name. Actonel. Those are the two that you really want to probably use more than the others because they've been used for a long time. They're cost effective. They come in generics, and they have the phosphonates is really a third generation biphosphonate, and it's been approved for the prevention and treatment of osteoporosis. So they do have studies that have shown that they have increased bone mass density by taking that, and it inhibits the activity of those osteoclasts, so it does reduce bone turnover. So that is one that's been used significantly throughout the years. Once it came out, it has been one of the biggest medications that has been prescribed. Also, there's salmon calcitonin that can be used. There's Avista. We use Avista in women who have had breast cancer because or had a high risk of breast cancer and no history of thromboembolic disease, and we're using it early on in postmenopausal women. Also, calcitonin is another anti-resorptive agent approved for the treatment of osteoporosis, and it can be used for women who cannot take or do not want to take estrogens or the biphosphonates. And it is available in a sub-Q or an IM form, and also even a nasal spray. And then the fluoride, oral sodium fluoride treatments have been used, as well as getting into using the Forteo or the Prolia. And these are expensive medications, but they're now being covered a little bit more often in patients with osteoporosis. Drug holidays, we can consider if they're having prolonged biphosphonate use, then consider thinking about checking those bone turnover markers during that time when you have them on a drug holiday. And then changing medications. Sometimes, they're just not responding well to the oral medications, and you may want to try the injectable therapy. And then sometimes using sequential and combination drug therapy. So combination is rarely used, but we may use sequential therapy using the anabolic therapy followed by the anti-resorptive therapy. So when you're treating the vertebral fractures, the analgesics, the heat, the cold, positioning them, making them do exercises, those are some of the other non-pharmacological treatments that you may want to go ahead and prescribe to your patient. Diet, exercise, smoking cessation, all of these are very important to educate the patient on. Making sure that they're wearing footwear and that they're really keeping lights on at night for fall prevention, because they really have a tendency to get up in the middle of the night, and that's when the majority of these falls occur. And then thinking about the appropriate follow-up. If they're on drug therapy, maybe start them on follow-ups 1 to 2 months, and then 3 to 6 months, checking their height annually, doing the bone mineral testing, and that's going to vary depending on the insurance companies, and then doing an annual physical on these patients to make sure that they are being monitored on a frequent basis. When do we need to consult these patients, other providers for these patients? Well, consulting is kind of going to be up to you. If you want to refer them to endocrinology or orthopedics, you can do that, but usually you can monitor them at home. I'm not at home, in the primary care home is what I meant to say. And then if you're going to be giving them Prolia and your office doesn't do Prolia in the office, you may need to refer them on to get those done. If they have secondary causes, if the labs and the clinical symptoms are just not correlating, you may want to go ahead and refer them out for further evaluation. If they're getting non-traumatic fractures and they have normal bone density testing, then there's something else going on, so you may want to refer them out. Also, if they're getting recurrent fractures and they're on therapy, why are they getting recurrent fractures? And then in severe cases or something that's unusual or something complicated, such as if they're having a combination of renal failure along with a lot of fractures.